I'm Hany Elmariah. I'm assistant member at the Moffitt Cancer Center in the Department of Bone Marrow Transplant and Cellular Immunotherapy. I'm here at the TCT TANDEM conference in Orlando presenting this phase 1 trial of CD8 depleted HLA mismatched unrelated donor lymphocyte infusion for patients with MDS, myelodysplastic syndrome, or acute myeloid leukemia. This study was done at the Moffitt Cancer Center in collaboration with Johns Hopkins University. And just as a little bit of background, the patients treated on this study have myelodysplastic syndrome, which is a high-risk hematologic malignancy that's either been refractory to primary therapy with Vidaza or decitabine, or that has progressed to secondary AML. Historically, those patients have a very poor prognosis with a very poor response rate to subsequent therapies. So we designed this novel cellular therapy that uses a donor lymphocyte infusion from unrelated donors, intentionally HLA class II mismatched the donor lymphocyte infusion so that it boosts the immune response of the patient to try to get them into a remission, ultimately to get them to an allogeneic transplant. A couple of unique aspects of this donor lymphocyte infusion is, number one, because it's HLA mismatched, theoretically there would be a risk of graft versus host disease. But what we've done is that we treat the cells prior to infusion by removing the CD8 positive T cells that are known to cause engraftment and also to cause graft versus host disease. By removing those, it allows us to do this in a safe way, but also the downside of that is that the cell infusion will be temporary, so the patients don't engraft permanently the way that they do with an allogeneic transplant. So the goal is then to get a remission and then ultimately to take these patients to an allogeneic transplant. So the study design was a phase 1 study doing a dose escalation, combining the donor lymphocyte infusion with standard induction chemotherapy, such as Clag-M or Vyxeos. And so the treatment schema is here. The patients got the induction chemo, and then the day after they're done with chemo, they get the CD8 depleted donor lymphocyte infusion. And then they remain in the hospital through the period of aplasia until they recover their counts. And then they get a bone marrow biopsy to assess the disease response. The patients on the study were pre-treated, very poor prognosis, high-risk features, including 4 of 9 patients that had p53 mutations. All patients had had some prior therapy and had been refractory, as I'd mentioned. The results, number one, is that we found the treatment was very well tolerated. We had no dose-limiting toxicities, even as we escalated to the highest dose on the protocol, which was 5 times 10 to the 7 CD4 T cells per kilogram. Notably, the main toxicity we did see is bacteremia, which is something that's common even in patients who get induction chemotherapy for leukemia when they have not been on this trial with the donor lymphocyte infusion. Some other important toxicities to be aware of is we did not see any incidence of graft versus host disease, and while we did see cytokine release syndrome, they were only grade 1 or grade 2 with no instances of grade 3 or 4, and also no treatment-related deaths on the trial. While it's too early to assess response, we did see a dose-dependent response in these patients. So I want to bring your attention to this figure, where at dose level 1, the lowest dose, we had 0 patients achieve a complete remission out of 3 patients treated in that dose level. At dose level 2, we had 1 of 3 patients that achieved a complete remission with therapy. That was this one. And then at dose level 3, we had 2 of 3 patients who achieved a complete remission. And notably, all of the patients who achieved a complete remission did proceed to allogeneic transplant. Another important aspect of this was, as I mentioned, this is a non-engrafting cell therapy, so we wanted to check that at the end of treatment, and we did find that none of the patients had had long-term engraftment. The other thing that was interesting in terms of feasibility is that for this study, we used donors in an unrelated donor registry that we recruited. It had 30 volunteers, and with just a donor pool of 30 volunteer donors, we were able to find a donor for every patient that enrolled on the study. And in fact, we had multiple donors that were suitable for every patient on the study. And the other interesting thing is that in some cases we could use the same donor for multiple patients. But so ultimately we're seeing, to summarize, a disease, a dose-dependent response with this novel treatment, reverses the immune system, gets patients into remission, and now we're enrolling patients on a phase 2 expansion cohort at Moffitt.